field shift before lunch, so hopefully I can make this interesting and exciting and provoke and spark some discussion and debate. There are a few cases at the beginning, and I'm sorry that these are repetitive of various issues that we've discussed, but I think it's because they are so, so important. So hopefully it just gives a practical example in terms of miscarriage and miscarriage diagnosis, and then we'll get to some other interesting things. So our first case is a 29-year-old. It's her first pregnancy. She's come to see you just about 6 weeks gestation based on her LMP. She's had some lower abdominal cramping. And this is what you might see. So it's an intrauterine pregnancy. You can see an intrauterine gestation sac with a yolk sac and an MSD of 10.7 millimeters. So what would your impression be at that stage? You can shout it out. I'll say it on the... What would you tell this patient? Yes, of uncertain viability, absolutely. So we said that to her, it's an intrauterine pregnancy of unknown viability, and it's her first pregnancy. We said we'll see you again in 2 weeks' time. So this is just a recap of PUV. So this is a diagnosis that we make based on first trimester transvaginal ultrasound imaging. Of course, you can say on a TA scan as well if you've seen an intrauterine pregnancy. Normally, you'd offer a transvaginal in case you can see a little fetal pole, but if you didn't and the patient declined, just rescan them. But essentially, if you see an MSD of less than 25 millimeters with or without a yolk sac and no fetal pole, you would that would be labeled as a pregnancy of unknown viability. Or you see a sac with a yolk sac and an embryo measuring less than 7 millimeters with no fetal heart, that would also be labeled as a PUV. But when do we repeat these scans? And obviously, Professor Bourne showed this data already, so in the interest of time, I'll just summarize that for you. So if you see here an MSD of greater than 12 millimeters, with or without a yolk sac, with no CRL, if it's greater than 12, you can rescan after 7 days, and at that stage, if you see really nothing, you could say it's a miscarriage. If you see a fetal pole in 7 days without a heartbeat, you'd rescan yet again in 7 days. And I think that's the bit that's really important. There may be rare occasions when you need to do a third scan. If the MSD in that first scan is less than 12 millimeters, with or without a yolk sac and no fetal pole, it's 14 days, okay? And then we would scan again, all right? Just be cautious if in that time you see a CRL, you may want to offer another scan. And if there's any doubt, and if it's too difficult to remember, just rescan them in 2 weeks, okay? You're just better off doing that rather than bringing people back lots and lots of times, okay? And this again summarizes this for you. So in this scenario, sorry, I'm going so fast. In this scenario here, we had an MSD of 10.4, so it was less than 12 with no fetal pole. We repeated the scan in 14 days, okay? And then in that time, she had a viable intrauterine pregnancy. We saw the fetal pole with heartbeat, and we could reassure her, okay? We didn't make any diagnostic errors or any issues. This lady, the plan was then made for routine antenatal care. So, of course, all the standard things, folic acid, vitamin D, book your pregnancy, see your midwife, whatever it might be in your country. Now, sadly, this patient went on to have that 12-week scan and was subsequently diagnosed with a miscarriage. Now, again, really, really important. She had a second operator. It was even at 12 weeks, do not be caught out. If it's sonographers at the dating scan will do a transabdominal scan. If they do not see a heartbeat, the expectation is then you do a transvaginal scan. It's really difficult to say that to the patient, even if you were scanning an early pregnancy, but you say, I'm not seeing what I expect to see. I'm so sorry. We'll have to do an internal scan to have a closer look. Most patients will be absolutely fine with that. You do a transvaginal scan, and then if you don't see a heartbeat, you take a measurement and then ask for a second operator, and then sadly you might have to give this diagnosis. Now here we can be certain that there was a miscarriage, firstly because the CRL is 17.2 millimeters, meaning over 7 millimeters with no heartbeat, and secondly because she'd already had a scan that showed a heartbeat, okay? Again, one area of caution. If you have a lady who comes to see you and had a scan and the CRL was 1 millimeter, with a heartbeat, and she comes back and sees you a few days later, and it's 4 millimeters with no heartbeat. Please, just, that's, I've seen that happen. Don't just wait. Rescan her in a week, because that 1 millimeter with a heartbeat, just do question that, okay? Because how can possibly we measure something at 1 millimeter with any certainty? So just do think about that when you're seeing women. Always think, could I get this wrong? And if I could, just rescan, okay? And that's very important. She went on to have surgical management. So again, this just algorithm shows that if you, how you can confidently make this diagnosis and making sure that you have a second operator. Okay, so another case. This is a live case. This actually happened, all right? So it is important. This is a 39-year-old. It was her first pregnancy. She actually got pregnant naturally while she was having fertility investigations, and she was about 7 weeks. She was seen in the IVF unit and sent to our early pregnancy unit, having been told she had a miscarriage. Our standard, we always rescan our own patients. That's what we do, and because we do see error, unfortunately. And this is what we saw. So we saw this. And what was being measured from the images was this, okay, this structure here, which, what do you, but actually this was the fetal pole. It was 5.6 millimeters. What do you think the structure they were measuring is? Chorionic bump, yeah, absolutely. And so that's what they told her. They'd measured that and said, but actually right behind, tucked in, right next to this, so you could see how easy it is to make that mistake, was a little fetal pole, but it wasn't so clear to us that we could see a heartbeat. So very simply, we just said to her, we're going to rescan you in 7 days. Now, it's obviously really hard to backtrack on somebody's diagnosis and really hard to explain that to the patient. But again, this is just about really good communication, explaining how we don't want to make a diagnostic error. Most patients will be understanding of that, okay? And actually, this was wonderful. She had a completely viable pregnancy. And then you could very much separate the chorionic bump from the intrauterine pregnancy, which is great. And interestingly enough, this patient went on to have a totally normal, healthy pregnancy with no problems, despite the chorionic bump and everything. So I think we have to go back again to basics. There are criteria. This has been based on huge diagnostic accuracy studies. So this isn't, something that people just decided upon because of opinion, all right? So this is really important that we follow these guidance in a stringent and rigorous manner. And so again, to diagnose miscarriage at a first scan, these two things have to be completely true. And if you're not sure, you just rescan. And then the chorionic bump, just again, a very quick point. There is some data that shows an association with miscarriage, but it is not diagnostic of miscarriage. And actually, lots of these pregnancies will go on and it will result in a live birth. So just do think about it. There has been some data that shows a possible association with adverse pregnancy outcome, but again, we don't have really strong prospective data to guide us on that, okay? I just saw this paper published last year, which I thought was quite interesting because the numbers are huge. It was 13,000 IVF pregnancies with chorionic bump. And again, you can see here that they have an increased risk of miscarriage. So if you had a chorionic bump, your risk of miscarriage was 25% versus 14% if you didn't. So there is clearly potentially an increased risk of miscarriage, but actually lots of these pregnancies went on to be resulted in a full-term delivery. So just be careful. We might see things and, you might want to bring back a patient for a scan, but these aren't diagnostic. And again, we go back to the importance of following the diagnostic criteria, which are this. And then there are features that might lead you as a clinician to be worried or concerned that the pregnancy may end in miscarriage, but these are not diagnostic. Now, if you want to make any of these features into part of diagnostic criteria, we need to do the studies for that, the proper prospective multi-center diagnostic studies. Actually, and a group did that last year. So this is a few years ago, sorry. This was about the amniotic sac sign. So, and I thought this was interesting. I just wanted to show it to you as an example of how we can convert something that we all kind of in our gut felt was associated with miscarriage into proper prospective study that demonstrated that. And yet we still can't include that in our diagnostic criteria, but I'll explain why. So this is the CRL, yolk sac, and you can see at 7 weeks, you start to see the amnion. And this empty amnion sign is either finding an amnion with a fetal pole with no heartbeat, or seeing a yolk sac and an amniotic sac within a gestation sac, but without an embryo. So how often does that happen in PUVs? Well, this is here, this table here on the left, and you can see that about 13% of the time you might see an amniotic sac with a fetal pole less than 7 millimeters without a heartbeat, and only in about 2% of PUVs do you see an empty amnion, okay? But actually, on follow-up, all of those ended up being miscarriages in this paper. So it is a good paper. It does show the association with miscarriage. But actually, we can't change all diagnostic criteria based off this singular paper. All these women anyway at the moment are going to be followed up according to our existing criteria, okay? What we now need to do to turn this into something that we can use clinically is obviously a large multi-center prospective validation study, which I think may start in London soon. Any questions about that? About amniotic chorionic bumps? No? Okay. Case 3. So this is a 29-year-old who's had 2 previous term vaginal deliveries. She came in at 6 weeks with some spotting, and we did a scan. And everyone was like, oh, looks a bit like, a bit worrying, this location of this pregnancy. And we scanning and we think, oh gosh, is this, where is this pregnancy? Is it in the cavity as it should be, or is it elsewhere? I'm a gynecologist, so Shahasha, I can scan over. And then we did this 3D, and actually you could see that it is an intrauterine pregnancy. And this is just a caution. Again, I know Professor Bourne talked earlier in his talk about common pitfalls, but this is something that you can see where people are brought to you with a suspected interstitial pregnancy, but in fact it's just the pregnancy that is angular or located more laterally within the cavity. So just do be cautious in these pregnancies. I hope the video works. So this is a pregnancy. You could see it is interstitial, all right? Really very, very much lateral, very little myometrium. And if you look, you'll see this is the endometrium. So, and there, this interstitial line sign, okay? So you just be careful, use both 2D and 3D, and if you're not sure, ask for a second opinion, all right? There are no real diagnostic algorithms to help us diagnose, or validate it, I should say, diagnostic test criteria, but you could see people talk about this interstitial line sign where it's separate from the cavity, and a very laterally placed pregnancy, and also very little myometrium around the pregnancy. But I know Professor Timmerman is going to talk about this more in his lecture. But just be careful on both sides, over-diagnosing interstitial when actually a pregnancy is just angulated laterally in the cavity. So maybe a bit of my pet project. A 29-year-old, first pregnancy, 12 weeks, presents with vaginal bleeding. And you see this. So very reassuring, a viable intrauterine pregnancy, but this area underneath and around the gestation sac. And what that, we normally term that, well, lots of terminology in the literature, but intrauterine hematoma, subchorionic hematoma, but these are relatively common, and I'm sure you've seen these in your own practice. And normally they're sonolucent areas around the sac. We normally measure them in 3 diameters. And you might comment when you're scanning, obviously not just about the pregnancy, but about the size of the hematoma, its location, where you might see the placenta or the implantation, and in relation to that, and also its location in relation to the gestation sac. So is it above the gestation sac? Is it below? Is it surrounding it? Is it adjacent? This was the evolution of this hematoma as the pregnancy went on. So you could see it got much smaller at 14 weeks and then resolved completely at 17 weeks. And actually, this patient had a totally normal pregnancy at term, which was wonderful. This was another case, and you could see again, she had a hematoma just below the sac that was relatively large, 6 centimeters. And again, it was smaller at 17 weeks and resolved at 19 weeks. And she had a live birth at term. However, there are pregnancies you see with hematomas where, unfortunately, they don't continue. And this patient had a hematoma at about 12 weeks. And again, relatively large, about just under um, uh, 8 centimeters. And then again, it was a bit larger yet still as the pregnancy progressed. But unfortunately, she came back and she had a miscarriage diagnosed later on. So what do we tell women with these hematomas? It can be really, really challenging, and there's not huge amount of data out there to guide us in terms of the management. But on the whole, I would say that they're not uncommon. So there's one large prospective data study that talks about an incidence of about 3.1%. Our paper was slightly higher, I suspect because of our cohort. We work at a tertiary center, slightly more high risk. We had a lot of IVF pregnancies because we work in a unit right next to an IVF unit, and IVF pregnancies seem to have more hematomas than others. And so for all those reasons, you might see them much more frequently. Most of the literature, both in the IVF cohort and spontaneous pregnancy cohort, suggests that there isn't an association with miscarriage. And actually, what's more important is whether a patient is bleeding and their bleeding score and the presence of heavy bleeding. Okay. However, there is more and more emerging data that some of these hematomas can be associated with adverse outcomes later in pregnancy, things like preterm birth, preterm pre-labor rupture of membranes, or growth problems in the baby. You would give progesterone in accordance with the NICE guidelines. So if they've had existing bleeding in a pregnancy and a previous history of miscarriage, so you'd give 400 Utrogestan vaginally twice a day up until 16 weeks. And also remember, it is part of RCOG guidance that in women they report heavy vaginal bleeding that is similar to menses or greater, that they should be recommended serial growth scans. So again, we have to make those links about what's happening in the first trimester to later pregnancy and offer women those scans. But there's still not enough data, but just as a word of caution, beware the woman who recurrently bleeds, particularly in the second trimester and with a hematoma. There's such a small minority of patients. We don't have the really good prospective data, but I could tell you from personal experience, they're the ones that end up rupturing membranes or delivering preterm. So this is the cohort where if you're working in early pregnancy, please make sure there's some communication with your obstetric team about that.
Last question. Do you think there's an argument with these hematomas, given the longer term outcomes and so on, about progesterone? Because you're looking at you're looking at a different endpoint. If you're looking at the ones who put recurrent miscarriage, but if you're looking at someone with a big hematoma, it's their first pregnancy. Some people, and you say, well, we might go to the Prem clinic or whatever. How exactly do you manage them and they say, look, what about some progesterone? Absence of evidence isn't absence of effect, is what I'm saying. What should one do?
I think nowadays, the answer is we don't have the data. However, nowadays more and more women are coming with these hematomas in a first pregnancy with bleeding, requesting progesterone. It is slightly difficult to deny them it, I have to tell you, and I find it really hard because they want to do everything they can. But what I normally say is if then they decide they want it, it's difficult to argue. The only thing I would say is I always try and put them back in with their high-risk maternity obstetrician and potentially then discuss ongoing progesterone treatment or serial scans and then further management. Because also once you start, it's very difficult to stop. That's one of the problems. So this is just some practical things. So reassure, consider surveillance, make sure you offer progesterone where appropriate, anti-D where necessary, and serial growth scans if they have heavy bleeding. I have 5 minutes. I have a case with a coil, but we're going to move on because I want to make sure that we get to the quiz, basically, if that's okay. I've got one case, but it's just a separate case just to demonstrate another point to us because today's about early pregnancy, but we will be scanning women in early pregnancy with other issues. So this was a 2-year-old who came to see us at 7 weeks, who basically had a positive pregnancy test, had not had a scan, and came to see us with severe abdominal pain and nausea. So, in fact, she had an intrauterine pregnancy that was viable and normal, but she had this appearance to her ovaries. Obviously, any other questions you might want to ask me, or anyone want to hazard a guess as to the diagnosis? Well, you got it, basically. This is the diagnosis. She had a torsion. Okay, and I just want to make the point that obviously, if you have a patient with symptoms who has a viable intrauterine, do think of other things. Appendicitis is the commonest complication, a surgical complication. Torsion, urine infections, renal stones. We've seen kidney stones. I didn't show one, but we did. We've had a recent case of that. So just make sure we think about other causes of abdominal pain in women who come to see us in early pregnancy. So here comes the quiz, because I've got a few minutes left, okay? I'll run through them. You think, maybe write down or think of the answer, and I promise we'll get the answers at the end. So for the following images, please indicate the location of the pregnancy. Choose the following options for this. Is it an intrauterine pregnancy, tubal, ectopic, interstitial pregnancy, cervical scar pregnancy, cervical cesarean scar pregnancy, or an ovarian ectopic pregnancy? We'll move on to the next one. So for this pregnancy, what do you think the location is? Is it an intrauterine, tubal, ectopic, interstitial, cervical pregnancy, scar pregnancy, or ovarian? I know.
Let's just some answers.
Okay, sorry. Oh gosh, sorry. Oh my goodness gracious me. Okay, this one. Please indicate the location. Which one? Where do you think this one is?
What do you think? Put your hand up. You put your hand up. You did. What were you doing? Adjusting your clothes? Bad mistake. It's like being in an auction.
We'll come back to the answers, I promise. And what about this one? Sorry. And this one? Okay, we'll go back now to the discussion. So what do you think about this one? Who wants to hazard a guess? So yes, it is. It's an angular intrauterine pregnancy, absolutely, because you could see it. It's not completely in the interstitial portion of the tube. What about this one? Cervical, yes, perfect. And this one? Cesarean scar ectopic, fantastic. This one? Tubal ectopic, yes, absolutely. There you go, team. You got 100%, okay? And I just... Oh, sorry. Is it me? Are you wanting me to finish? No, sorry. No. Okay, so this is so which ones? So this is just to make a point about pseudo-sacs and gestation sacs. I think the point of this, does anyone want to hazard if this was intrauterine or an ectopic in the end?
Sac or no sac?
Sac or no sac?
Sac or no sac?
This is a game we play in our MDT, so not a joke.
Okay, hands up who says sac, gestation sac. Put your money where your mouth is, come on.
Okay, sac for this, and then B, no sac, C. Okay, so actually, oh gosh, I'm sorry. Here we go. So this is actually intrauterine, this was intrauterine, and this was an ectopic. Just goes to show you just don't know. So please, these should all be treated as PUL and managed alongside the PUL protocol. This is, what do we think this is? Which ones are interstitial or angular? What do you think about this one? Okay, and this one? C, sorry, let's go to B then.
It's a Merkel.
Okay, this one? And that last one, D? Okay. Actually, this is interstitial. This was actually an angular. It does communicate with the cavity, although probably doesn't, is not looking very well on projection. This was an angular, and that was interstitial. And then can you name these structures? Okay, what do you think A is out of these?
Oh, it's obviously a miscarriage.
A bump, okay. And B, what is B here? And C, this thing here? Coil, yeah, very good, exactly, absolutely. Okay, lovely, and I did it just in time.
Right.
Thank you.